If there are any questions from the floor, those can be addressed now. Thank you, ma'am, and thank you, sir, for that excellent overview on drugs used in developmental delays. The next session is the panel on the management of ADHD. May I now request the moderator, Dr. Venkateswaran, Senior Consultant Psychiatrist, Chennai, to take over. I request the panelists of the session, Dr. Kiran Makhija, Dr. Sraboni Chakravorty, and Dr. Anuradha Srinivasan to occupy the dais.
Good afternoon, everyone. I'd like to thank the organizers for this wonderful opportunity. So next 40 odd minutes we'll be discussing overview of ADHD management, psychosocial interventions involved. So we have three esteemed speakers in this area, like who are going to give us insight about these various headings. So we shall move into the topic. Sir, so first question is directed to Dr. Kiran. Sir, as a pediatrician, please share your experience on children with ADHD in your everyday clinic. So how often you see, like how do you make diagnosis in the very short time?
In my clinical practice, I have seen the ADHD frequently. The patients, they are coming to my clinic and with the symptoms, prominent symptoms, as the name suggests that it is the attention deficit hyperactive syndrome. And the attention deficit means you can see that in labeling in the different age group, we can find that it is one of the most common childhood psychiatric disorder, and it affects about 5 to 7% of the school age children. And there are 4 types of the ADHD, as I have enumerated. The attention deficit type of the one is and second one is the hyperactive type, and third one is combined, and fourth one is of the unidentified or uncategorized. And usually we find that the diagnosis is in the childhood itself, less than 12 years of age, and as has got the chronic process, and we find in the adulthood also. If it is not treated properly, it will go for the lifelong complications. As the symptoms of the patients, you can categorize in the preschool age. They are very much of the overactive, very highly active they are, and believe me, you cannot differentiate in this age group whether the symptoms are really of the ADHD or because of the normalcy. So they don't listen to the mother when they are called, and they also have no sense of danger. So sometimes they land up into the accidents also. And for the attention, they don't play for more than 2 or 3 minutes for the same game. The games are changed, and for the next, if you will find in the school age also. Moving to the next slide, please. So in the primary school, it is expected to these type of the kids, they sit and in the school properly, and in the assembly they should be in the discipline, but because of the inattention or the impulsivity, they cannot. There will be the brief activities less than 10 minutes only, being forgetful, disorganized, and they get easily distracted from the classroom also. The impulsivity, you can see that the acting out of the turn, always they try to be the calm fast and shout in between, interrupting other children, and they have the rule breaking in school, thoughtless intrusion on the peers if impulsivity is higher, and getting into the accidents, the age group, it is increased. And when we see in the adolescent group, they are more of the mature type of the symptoms. You can see that overactivity, it is not visible in the form of you can say in the physical activity, but you can interpret it easily that they have the inner restlessness and some fidgetiness is there. Impulsivity can be seen in having the risk-taking behaviors, because of the risk-taking capacity and capability is there in that age group, and substance abuse is also seen in these type of the case. And inattention, you can see by the organizing task, what the task has been given, they will be having difficulty in organizing that, they will be having the procrastination. They in between also, they do not complete the project and just stop. And frequent missing of the deadlines, always the homeworks, the projects, they do not do in the time. These are the usual symptoms we find in the age group wise.
Yes, sir. Thank you, sir.
And one more thing I want to say, that these symptoms are of usually we see, but moving to the next slide, please. Sometimes when some incentiveness or some rewards are there and different conditions are there, when these symptoms are actually get regressed, or you will not find. With the clinician, child is engaged is one-to-one interaction. When in clinic, you will don't find these type of these symptoms. And in the novel settings, in the new places also, like in clinic also, under the close supervision of teacher, these kids will have the normal type of the behavior. You will not find the ADHD type of the behavior if they are engaged in the interesting activities or in the getting some rewards or stimulation in the TVs. But when you give some project or give some work, they will find difficulty in facing that.
Yes, sir. Thank you, sir. As sir was mentioning, if you see the symptoms evolves over time, it starts with motoric hyperactivity in the preschool age, where the children will not sit, jump. If they come to your clinic, you will be tired, like they'll be all over the place. But once you see, as sir was mentioning, the hyperactivity part comes down, it will be replaced by more of fidgeting, like they'll be more fidgetive. Then slowly the inattention comes, then impulsivity will be more noticed. And if you see over the time in adolescence, this will be like they will present with inattention that will persist, more of risk-taking behavior. So this is how ADHD symptoms evolve over time in our routine day-to-day practice. This is what we'll see. Sir, as a pediatrician, what are the medical and psychological comorbidities or sometimes the other condition that may present as ADHD?
Yes, moving to the next slide, please. The comorbidities usually seen with the ADHD, like the development, it can be categorized into three: the developmental, psychiatric, and the medical. For the developmental, the intellectual disabilities, speech and language disorder, learning disorders, the motor coordination disorder, ASD patients, the tic disorders. These are the developmental comorbidities. And the psychiatric comorbidities are the oppositional defiant disorder, conduct disorder, mood and anxiety disorders usually seen, and psychotic type of the disorders. Substance abuse have been seen in these type of the adolescent kids particularly. For medical one, it is tics, seizures, thyroid abnormalities and malnutritions.
So what are the medical conditions we have to consider when we diagnose ADHD, and especially when we are going to treat ADHD?
Yes, the medical conditions which may present like the ADHD, when the patients are on the, they have faced the head injury, particularly the inattention type of the behavior you will find in the head injury patients. The thyroid abnormalities will be there. You will find some of the issues like ADHD. The absence seizures, rarely in the genetic syndrome, Fragile X. Since the morning we are seeing the slides of the Fragile X, and many of the cases we have find the behavior like the ADHD.
Sure. Sure. So we'll go to Anuradha ma'am, then we'll come back to the comprehensive assessment part.
Yes, yes. Few of the drugs, they also, pardon?
We'll come in the end, sir.
Yeah. Okay.
Ma'am, what are the rating scales and psychological assessment you use in ADHD commonly when you have a kid with ADHD? So what are the psychometry that is considered?
Yeah, thank you. Hello. Yeah, thank you. See, the common rating scales, I just wanted to tell a point about it, because these rating scales are different from the diagnostic scales, and they mainly help in assisting the diagnosis, and they are definitely do not replace a clinical history, a good clinical history and a clinical examination, and the examination in the setup where you are seeing the child. So the common scales which are there are the Vanderbilt parent and teacher rating scales, which is done between ages of 6 to 12, and the Connors ADHD rating scales 6 to 18 years. And there is a preschool version which is for children who are 4 to 6 years. The ideal age we see children who come for these as 3 plus usually, unless they are identified at play school. And these scales are actually having different versions as parent and teacher scales. So there is a separate form for the parent to fill up and for the teacher. So this is based on the various behaviors which Dr. Kiran just explained. So they have to be scored as present less often or very sometimes or very often or always, and based on that they get a score. So this is based on both symptoms and the child's performance levels.
And
so, but there are also certain previous slide, simpler scales like the child behavior checklist or the CBCL, which is nowadays being commonly used because for the simple reason, I think it has about 18 items or something, and it could be done in a shorter time. So it can be finished with practice, of course, by 10 to 15 minutes. So that it will be a quick guideline to pick up the child with ADHD features and refer for early intervention. And there are other scales like the clinical global impression and the clinical global assessment of functioning and strengths and difficulties questionnaire. Probably you all could look up on it because those actually help in not only the diagnosis, and most of these rating scales are also used to monitor the progress of the child periodically while the child comes for review.
so overall, like we can, as ma'am was telling, we can divide into a narrow spectrum scale which just measures DSM criteria of ADHD, like corners or Vanderbilt scale, or there is a broad spectrum scales like Brown's ADHD rating scale, which covers varied functions like dysfunction, executive function, all those things it will cover. Okay, and like there is different sometimes this teacher rated, like we ask report from the school, the same Vanderbilt teacher rating scale is there, parent rating is scale is there. As we move on to adolescent, there is self report scales as well, like where they bring their subjective inattention. Sometimes that is not observed from the outside, they may be daydreaming. If somebody see, like it is like they will be listening there, but they will be somewhere else. So even youth self report questionnaires are also available. So when we have a confusion in diagnosis, when we are not sure about ADHD, then we ask for this various rating scales. Usually the dictum is get in whenever a child with ADHD get input from multiple formats like parents, teachers, for us to confirm the diagnosis of ADHD. Ma'am, what is the role of IQ when will we ask for IQ or cognitive assessments in ADHD?
So in ADHD we have to be very careful. The IQ assessment is not a mandatory requirement, especially when we are dealing with a preschool or a early childhood. It would be too early to get the IQ assessed. Can I have the next slide? Yeah, so the routine psychological testing is ideally not required. And so the clinician or the pediatrician has to be very clear, because if the parent asks for it also, we would be able to tell them that if the child is actually having severe ADHD features, then the child is not going to perform appropriately for that IQ test requirement. So we have to convince the parents and counsel them that regarding the IQ, it is first the child's early intervention and addressing the skill deficits and the behavior management would be important. And the IQ testing can be done after adequate symptom control of behavior management. So, and again, repeated IQ assessments are also not indicated unless it is specific for certain say for the school requirement or for the disability card. So those purposes we could definitely do the assessment.
Yeah. So as ma'am was telling, the IQ assessment is not mandatory for diagnosis of ADHD. It is usually done to pick up comorbidities. For example, like LD associated with ADHD or intellectual disability associated with ADHD. In these situations, to plan overall rehabilitation, we will ask for IQ. Certain IQ scales like WISC, Visual Intelligence Scale for children, like there are so many subheadings which is attention dependent. So sometimes if we are not able to diagnose clinically, we can use one of these scales where if some for example working memory, if that alone is very low, compared with other domains, we can indirectly assume the child is having inattention, in performing inattention. So as such, the IQ is not mandatory in routine ADHD management, is usually done for the comorbids. Ma'am, what is your experience in early intervention, that is preschool children with ADHD, managing preschool children with ADHD?
So if you can see the picture, it's self-explanatory. So one is first we need why early intervention is needed. Because all of us have been hearing repeatedly early intervention, but it's very important that the parents are aware of the condition, and so they will be able to tell to the other members of the family about the condition and that this needs early intervention. As they were discussing in the morning, people tend to get help quite late. So the identification comes either from the school, the teacher may identify, or the parent. So it is important that it improves the relationship between the child and the family. And of course in school it would help the child to get a proper program which is tailor made for that particular child, so that the teacher can be educated regarding the need for special accommodations for the child, or the child may need certain additions in the classroom. So which I have another slide, but this early intervention also improves the child's behavior. So the classroom behavior, and it also helps the child to improve his or her play skills. So in this way early intervention is very important, and I think all of you are aware of the neuroplasticity. So the earlier the behavior changes and the sensory inputs are given, the outcome is going to be better.
And management of preschool ADHD, ma'am, like what are you like to consider in management of preschool ADHD?
Yeah, so the previous slide, yeah, thank you. So when a child with the preschool ADHD comes to the clinic, I think the first duty should be to just listen to what the parents and the family has to say, and we will have to pick out the significant points from that. They may be telling like their own stories and their emotions, everything put together, but we as clinicians must be able to identify the salient points from that. And definitely you have to establish a good rapport first with the parents, then the extended family, and ideally liaison with the school, because they all depend on what the doctor is going to tell. So we will have to be clear with the establishing a rapport and communication of the diagnosis, and it is mandatory our duty to tell about the possible genetic nature of the condition, and also the environmental factors. So the epigenetic factors which we say, so it would be the social media, the addictions, or the media gadget addictions. It could be different things where the child is not getting adequate time, and also it should be told that since it could be a genetic thing, there should be no guilt or blame. All these factors should be taken into account, because it will be the first meeting, and so then we will communicate the diagnosis and also the comorbidities which Dr. Kiran was mentioning. And the mode of intervention, I think we went through the pharmacology some time back, and Dr. Venkateswaran is a better person to talk about it. See, in preschool, what we should see is, it would be first the behavior interventions, and medications only come at the last. So the various things could be the behavior modification, and this could be done basically through the parent training and the teacher training. So this should be done. Cognitive behavior therapy and all will be for the older children.
Okay. And accommodations, ma'am, like
yeah. So again, accommodations in the preschool aspect, I think it's very good to start the accommodations and the routines from preschool, so that this child can carry on the same thing as he grows. Only thing, he may move from the pictures to the device, where the pictures can be put on the device. He can form a communication, follow a particular communication method. So structure and routine is very important. So for all of us, we do like to have a structure and a routine. So just like that, even preschool kids would love to follow a routine. So entering the class, wishing the teacher, having a rhyme time or a circle time. So like that, for this ADHD child, a proper structure and a visual schedule. So you put all the pictures or sequence of the activities for the day in an order, and it could be stuck in the classroom, or even some have these cards which they finish and then peel it and place it inside once they finish that particular activity. So and then important is a verbal prompt. You must have heard that for children with preschool kids with ADHD, they are made to sit in the first row so that the distraction is avoided. Then they give a short breaks in between doing a particular activity. We've heard that they don't do the task completion. They are distracted every 2 minutes. So a timed break, they can be given a break card which they can show and they can go for a break. And positive reinforcement. So it could be stars or whichever this child likes. So these systems could be incorporated both at home and at school, so that they have a uniformity.
Sure. Thank you, ma'am. So overall, the summary of preschool management, see, our most crucial part should be on psychoeducating the parents, because they are going to hear the diagnosis for the first time. So they are going to shocked. Because our effort, major effort, 50-60% of the effort, if we don't psychoeducate properly, then they are going to go for a doctor shopping. Different people gives different inputs, and they are not going to accept to the diagnosis. The child will keep suffering in the school. So directly, if we are going to be jumpy in management in preschool children, then that is not going to help the child in long run. So as ma'am was telling, so educate properly, educate what are the components, discuss interventions the child may require in the future. For example, sometimes I used to prepare children in preschool for medications after 6 years. That preparation really helps. Okay, so right now your child don't need medication, so they'll be happy, but he may require after 6 years. So that is like prepare them for future requirement of medications. And as the second point ma'am was telling, the comorbid, sometimes it's ADHD is a developmental disorder, it can have other developmental comorbidities as well. Maybe some children will have spectrum as comorbidity or a speech language disorders comorbidity. So we should make our effort in managing the comorbidities. Then most important thing, classroom accommodations. Classroom accommodations, like where the child should not be left alone in the class. Like child should not keep roaming around the class without any structure, or at the same time they should not be too punitive as well, like hitting the child, scolding the child. They will lose their self-esteem. So classroom accommodations are next most important thing. So the treatment of preschool children with ADHD is parent and teacher trained behavior management. Okay, sometimes some centers give behavior therapy with children. That is not the actual behavior therapy. It is the parent and teacher who get trained in managing the behavioral management techniques, like ma'am was telling about positive reinforcement, handling difficult behavior. These are the crux of management of ADHD in preschool children as per CDC guidelines. And when we come to pharmacotherapy, if one aspects of pharmacotherapy, it's stimulant or the treatment of preschool ADHD if it is required. Okay, usually the pharmacotherapy is not required. If at all the child is too hyperactive, injury prone, then we can consider stimulants. Sometimes we may use pharmacotherapy for comorbids. For example, severe dysregulation, mood dysregulation. The child is having significant temper tantrums, as sir was mentioning. ODD with ADHD, they will have temper tantrums. In those situations, we might use risperidone as an off-label management, but it is not for the core symptoms of ADHD. Core symptoms, still I will go with the stimulants in the management of ADHD if it is required, but it is not mandatory before 6 years to manage ADHD with medications. After 6 years, it is better to use. So this is the overall summary of preschool children with ADHD. Thank you, ma'am.
Thank you.
Sir, again I'll come back to Kiran sir. Sir, as a practicing pediatrician, what are the components you think important in making the diagnosis of ADHD? So we should not miss these components. So as per, what is your take on this?
Yes, for managing the ADHD, we have to confirm the diagnosis, and as well as we have to evaluate the the problems which have been arised by the morbidity, that is the ADHD, and how the ADHD is affecting the life, because we have to see overall as a kid to be developed normally, and the parents to not be suffered lots, otherwise they will be burnt out. So we have to evaluate the kid as a comprehensive management, as a comprehensive evaluation is required first. So the component of the comprehensive assessment and evaluation, it is the core component, that is the history. That is the main important thing. By the history only you will come to know that this particular type of the kid who is coming to our clinic is the ADHD. And we have to get the information from all the sources, not only the mother, not only the caregiver who is coming. We have to ask the other family members, the grandmother and the other members of the family and the neighborhood also, the teachers, they are very important source. We have to see the development and the psychiatric history, the comorbidity, and for the evaluation as well as for the management purpose. Medical history is very, very important. Sometimes the patient, they are coming from the other clinic. So we need to have the what are the treatment already be given or the side effects and how the patient is taking the medicines, or the medicine itself causing some of the ADHD symptoms. So we have to look out. And the physical disorders, the physical examination is important, like the genetic as well as for the medical as well as for the treatment, and the associated comorbidities like the malnutrition or the thyroid abnormalities. The family history, very, very important. Many of the ADHD, they have the family history of the other, some of the other type of the psychiatric or the neurodevelopmental disorders in their family itself. And we have to see the history of the any sudden death because of any of the reason, that has to be considered. Treatment history, as I have already told you. Sleep pattern, usual sleep pattern has to be seen in this ADHD. They are very much hyperactive. We need to see the sleep pattern. And also this disorder is not of only the diagnosis, but we have to see what this disorder is causing effect on himself, the patient himself, the family, as well as in the society also. Moving to the next slide, that will show the dysfunction of this disease. Back to this, back one. Yes, the history of dysfunction, the domain involved, the academic, family, social, interpersonal, legal aspect is also very important in the adolescent. The peer relationship, the occupational in the adulthood, severity of illness, overall severity you have to see. The secondary impact of the illness on the patient itself, like if the patient is having the secondary depression, or the perpetrator of the bullying, or the bullying victim himself may be the victim, or stigma, the parental abuse, because many of the parents, they leave these type of the kids by their own, and sometimes they beat up also and don't take care of them. The secondary impact on the life of the caregiver, sometimes they are the burned out or the distressed, they have the psychiatric problems also, the burden is there in the family and the stigma from the society. But the important thing is that these ADHD kids are not of the lower IQ. Many of the ADHD patients, they have the good IQ and they have the good strength of them, and we need to evaluate and we have to flourish them. So physical, psychological, cognitive, or the contributory to the creative activities of that kid has to be evaluated. Sometimes they are good in the sports, or sometimes in the sketches, coloring, or they are very much obedient also, sometimes you will find that. So that has to be taken care of, and the assessment of the current needs, what the academic, psychological, social, and what the madam already told, that for the assessment we have the scales. Mental state examination is very important, and overall comprehension that's to be done.
Thank you, sir. Like we have to have a 360-degree of the child to have a proper management of ADHD. So we'll go to Sraboni, ma'am.
Hello.
Ma'am.
Am I audible to everybody? Yes, good afternoon.
Yeah.
And thank you for inviting me here in this GDPP conference. I'm very much privileged to be here with you today. So, actually, the ADHD children are now grown up, as Anuradha ma'am and Dr. Kiran has told you. assessment done, and some early intervention started for few of them and not for all. So they are grown up to older child, maybe in teen. So they have another problem to deal with.
Sure. And what are the comorbids and complications you see in school age and teens with ADHD?
Yes, we have some comorbid condition in school age children and also the teenage. They have anxiety because they know now they can assess themselves, and they are very much alert how they are assessed by other person in front of them. So they feel anxious, they may have depression, there are rejection from the society, and they feel very much depressed for that, and along with that may be associated ODD, oppositional defiant disorder, conduct disorder, and learning disability, specifically post-COVID period learning gap, because online classes are going on and these ADHD children could not follow this online class. I have seen many cases they are too standard lower than their present standard, so they cannot cope up with the present class right at this moment. So there is a problem with this, with their issues with ADHD, and autism spectrum disorder may be associated with that. Already covered tics and Tourette syndrome, substance abuse, sleep apnea. They are very prone to substance abuse, risky behavior, and adolescent period is itself is a very problematic period. Hormones are very high. So we tell that a good car with good engine, with much fuel, but prefrontal cortex has not developed yet, so driver is not there. So adolescent is a problem, and adolescent with ADHD is something more problematic, two problems together. So there is, in present era, there is internet addiction, which added, so some always there with this internet and not doing anything, and delay in submitting their project, rejection from peer, rejection from school, and punishment for their parent, and they may be having the parental problem for them. So this is the complication. They may have substances already I have covered, and increased risk of accident already I have told. Suicidal ideation. So just a story few days back happened in Kolkata. There was marital disharmony within the parent, and child was hyperactive, ADHD child, and teacher punished him for not submitting project. Was in class 10th. So punished him. Just go outside the class, and that fellow jumped from the 5th floor and committed suicide, ended his life. This is very bad thing, it's very tragic thing. So we, the pediatrician, should be very cautious and should teach the parent, should teach the school also for identify early. And missing, already I have told that missing assignment, withdrawal from friend, and change in appetite, deficit in school grades already covered, and feeling of failure. So rejection sensitive dysphoria will be with that, and severe bullying by the peer group. These are all complications.
Yeah. Yes, ma'am. Thank you. So as she was telling, if you see the evolution of these complications, it will start with an externalizing behaviors, like they'll be jumpy, hyperactive, and they'll be intrusive. Slowly as they grow up, they will start developing more and more internalizing symptoms like depression, suicidal ideas, addictions, etc. So if we don't treat when they are having externalizing behavior, if we don't implement proper strategies, then it is inevitable. They will have more and more internalizing symptoms, and slowly they will start developing other psychiatric morbidities. So then it is mostly rehabilitation rather than prevention. Okay. So next is, what are the psychosocial management of ADHD, ma'am, especially school age and adolescence?
Yes. So next slide. Yes. So already covered. It varies with age, our treatment. So I am going to psychosocial intervention. It's some intervention with the child and the social, surrounding with that child. What is that immediate environment? That is their school, their parents. So parents should be taught how to manage this child. Okay. So these include behavioral intervention of the child himself or herself, parent training program, cognitive behavioral therapy for the, for the older, for the teenager based, and school based intervention for older child, and also for the teenager, and academic support, coaching, social skill training, executive, intervention for attention and executive function, better executive function, mindfulness. It has enormous effect on your self control, and relaxation exercise training, psychological relaxation exercises has got enormous effect on your control and this impulsive behavior, and also the physical exercise will give you release of endorphin, and that release some your impulsivity and hyperactivity. So behavioral modification itself just help a child to change his or her behavior. So it's associated, which is associated with ADHD. It include techniques that have token system and desired behavior to be reinforced, and which is not desired, that will be reduced. So it use that your operant behavioral technique, that ABC technique. Okay, next slide. So parent training, there are many names of their different types of parent training available throughout the world. Behavior training management of parent and family, so showing ways they can provide support for their teens. PTBM is one type of therapy, and parent child interaction for the lower childhood, and positive parenting style, that is triple P, and a family counsel, family therapy. Parent typically attend several sessions, and they learn how to handle and better parenting style, and they help to acquire the behavior we want. So next slide. So there is little bit difference in between older and adolescent. So for older children, clear instruction and tasks should be broken into small chunks, because they don't have more attention span, and allowed to complete it after taking some break, and clear system of reward for good behavior to be there, and regular communication with school and home tuition teachers, and you should be role model. You are with mobile phone and searching for the social media, and you are telling all the time that don't do it, this is bad. It will not affect your child. Okay, so for the adolescent, just free yourself. For the adolescent, so there should be healthy boundaries to be set up, and reward your positive behavior. Just remember that they are very much ashamed if they are being punished in front of others. So what happened in that child? So in a private area you can tell them, and you can in a school also you can take to a private area and talk to him, not open to all, and it will it make a very severe complication, as like suicide also. So you should, and always you try to become a role model. All the parents should try to become role model. Next slide. So parent-child interaction therapy, this picture is for my clinic only. So it research shows it reduces negative child behavior. So always our parenting style tell that no, don't do this thing, it's not good. So we take the parent together along with our members, our psychologist and our special educator. They teach the parents how to handle their child, and the child will do accordingly. Next slide. So effective consequence and reward should be we should plan for that, and we should tell them what to do and why they are punished, and there should be a reward system. We should reinforce their positive behavior. Okay, and it should be immediate. It should be immediate. So the behavior we can reinforce it. Next slide. So executive function we have to take care. So it improve your planning and all these things, and your self regulation, organization skill, attentional control, emotional regulation, all these things. Next slide. So parenting training improve child executive skill. I'm not going into details, but because time will not allow me. Teach the children skill rather than just expect that child will copy from you. Then response innovation is very much important. So innovate response, immediate response to be innovated. Some emotional control skill to be trained to the child. Next one. So tips for the parent is very much important. Build rapport and be understanding. Show cultural sensitivity. Avoid negative talk. Avoid power struggle. Avoid power struggle. Don't assume or make judgment. Be encouraging. Just pick up their positive one and go with that. Encourage some some creative work like drawing, dance, what the child want to do, and physical play, exercise, mindfulness already covered. Adequate sleep, 8 to 9 hours sleep is required, and manage their problem. Next slide.
Thank you, ma'am. Thank you.
Okay.
So as a summary, if we see like ADHD preschool, it is mainly parent-trained behavior management. Medications are not mandatory. But if you go to school age, medications are, give me 30 seconds. Medications are the treatment of choice, along with, as ma'am was telling, parent-trained behavior management. So the parents and teachers will be taught to handle the child. Slowly we'll start giving inputs to the child. But as they reach around 12 years, adult teen, 12 years, it is medications plus CBT. Whatever ma'am was describing is component of CBT, executive function. That is teaching them to plan, teaching them to organize, being mindful about their condition, or addressing depression, which is an outcome of ADHD, addressing suicidality, which is an outcome of ADHD, improving the family's interaction with the child, that is part of family therapy. Okay, so these are the crux of management of ADHD. So it starts with the parent-trained behavior therapy, slowly it involves the entire family. At some point the medications will come. This is the overall summary of the management of ADHD. So I like to thank all the speakers. They have given a wonderful insight on the topic. Any questions? They are open.
Thank you.
We from the panelist and also thanks our moderator who has done excellent job within a frame of time. Thank you very much.
Thank you, sir. Thank you.
I thank the moderator and the panelist for that important session on ADHD management.